ECHO Session. I'm sure we'll be joined by a few more people, but we're going to start on time because we've got a full program. You've probably all seen the slides, just reminding you of some of the ECHO principles. But in particular, really keen for you to introduce yourselves in the chat, your name and location, and maybe if this is your first time, just let us know that you're new to the program, and we welcome all our new participants. It's great to have you joining us. We have two speakers today. I'm going to briefly mention them both at the start, just to give you a sense of the program. So we're going to start with Dr. Sunil Kumar from Pallium, India. Sunil is the additional director of the Trivandrum Institute of Palliative Sciences in Kerala, and he presented at our last month's session as well on a QI project that he led as part of the PC PACE program. So he's familiar to many of you already. And our second presenter is Dr. Jess Mather-HIllon, who's joining us for the first time. Jess is a palliative care consultant here in Australia at Clare Holland House in Canberra, where she works primarily in the community. And as a special mention, Jess has a 2-month-old baby, Lizzie, who we were hoping might join us, but maybe Lizzie's been cooperative and gone to sleep, I'm not sure. So I think without further ado, we will move on to the presentations. First one from Dr. Sunil, an overview and some case discussions about the use of methadone in pain management and palliative care. Over to you, Sunil.
Thank you, Audit. Good afternoon, everybody. I hope I'm audible.
Yes, sir, you are.
Okay. So let me share my presentation. Okay. So today, as all of you are expert in pain management and in using other opioids, methadone is a new drug which has been introduced into Indian market in 2018 only for pain management, but it was available for addiction as a substitution therapy previously in India, but it is used as an analgesic since 2018. So I am planning to cover these 5 objectives. Methadone is different in pharmacological properties compared to other opioids. All of you might have heard that methadone has many side effects, and I have even heard that methadone should not be used for pain relief. So there are many things. So we will go into that a little bit. Then how will we monitor the patients when we start patients on methadone? And another important question is that who are the appropriate patients to start on methadone? And I know that there are at least a few people who want to start methadone, but they haven't got an ideal candidate for starting methadone. So that's one of the important things. And last, how will we convert an opioid to methadone? So first of all, pharmacology. So methadone is an isomer of 2 compounds, S-methadone and R-methadone. We know that all the opioids act on opioid receptors, and most of the opioids, potent opioids like fentanyl or morphine, they all are mu opioid agonists, but methadone is an agonist at all the opioid receptors, mu, kappa and delta. So that's one mechanism of action. In addition, it acts as an NMDA antagonist. So there are various viewpoints about this, how strong it as an NMDA antagonist, but it acts as an NMDA antagonist also. Then it also acts as a tricyclic antidepressant. So it inhibits the reuptake of noradrenaline and serotonin. So these are the three mechanisms of action by which methadone acts. So you know that by all these mechanisms, it will be helpful in treating pain, because NMDA antagonism and tricyclic antidepressant action would be helpful in treating neuropathic pain. And NMDA antagonist is helpful to prevent and reverse tolerance that can occur to opioids. So these are a few advantages of using methadone. But in the last, I have pointed out about torsade points. So methadone can act on HERG gene, that is human either ago-go related gene. It is there in smooth muscles, but abundant in myocardium. And when it blocks HERG gene, it can cause torsade points and sudden death. So this is the most scared side effect of methadone. So the first three are advantage or beneficial in treating pain, and the last mechanism of action can lead to torsade points. Okay. So we know that morphine can be given through many routes. Likewise, methadone is also can also be given through orally, parectally, subcutaneous, IV, etc. But compared to morphine, methadone can be also administered sublingually, and it has a fair rate of absorption through sublingual route. And metabolism, like morphine, it is also metabolized in liver, but there are many cytochrome enzymes are involved in the metabolism of methadone, so that there are many drug interactions that can occur. And it can either increase the dose of methadone or decrease the dose of methadone, which is available in the blood. And it is distributed. Yeah, I am coming into that. And excretion is mainly through bowel. So it is supposed to be a safe medication in renal failure. So you can see that when you administer methadone, what happens, it is available in the blood for some time, maybe for 2 to 4 hours. I am talking about a patient for whom we are administering methadone for the first time. So for the first 2 to 4 hours, it is available in the blood, and it can give you pain relief for that time. But immediately after that, this will disappear into cells, where it binds to the tissue binding sites. And once these tissue binding sites are saturated, then only the methadone will be released into the systemic circulation, which is sustained. And only a minute fraction is available in the blood for acting as an analgesic. So the tissue binding sites has to get saturated, and this happens or it will take about 5 to 7 days in normal healthy people. So you should not increase the dose of methadone before 5 to 7 days. But in elderly and in patients with altered liver function, it may even take up to 2 weeks. So compared to morphine, one of the most important difference would be we should not increase the dose of methadone till 5 to 7 days at least. But in case of morphine, we know that we can increase it every 24 hours. So the half-life or the time taken for sustained blood level is 5 to 7 days. So as I told, it is extensively metabolized in liver, and you can see there are many cytochrome P enzymes involved. So there are many drug interactions. So these are the drug interactions which you can remember by this acronym. And there are some drugs which can be a cytochrome P inhibitor, G-Pacman, that is grapefruit, protease inhibitors like medications used to treat patients with HIV, as well antifungals like fluconazole, ketoconazole, etc., cyclosporin, cimetidine, macrolide antibiotics like all the macrolide antibiotics, azithromycin, clarithromycin, erythromycin, amiodarone, and non-DHP calcium channel blockers, that is verapamil. So when you give this medication along with methadone, it can actually increase the dose of methadone. So maybe you have to either decrease the dose of, suppose you are giving azole antifungals like fluconazole, usual dose may be 150 milligram for 7 days. But we may give it for 1 day and we'll wait for another 3 days to see how is the effect. And that might be enough. Otherwise, you have to find out other antifungals uh, which will not interact with methadone. Or else you can reduce the dose of methadone by 25%. So these are some strategies which we can institute when you start a patient on cytochrome P inhibitors. Like there are cytochrome P inducers also, phenytoin, smoking, phenobarbital, oxcarbazepine, rifampicin, carbamazepine, St. John's wort. So this can cause reduced methadone in the blood level, and you need not do anything, but you have to watch for whether this patient has any withdrawal reaction. Okay, so when you start a patient on methadone, what are the things which we need to monitor? So the most important thing is that whenever we do investigations or something or any intervention, it should be well aligned with goals of care. Suppose the patient is near end of life. So in such patients, we need not monitor or do extensive investigations and see whether this patient is fit for methadone therapy. But if the patient is undergoing a curative or palliative oncological intervention, definitely we should do all the baseline investigations. So the usual baseline investigations done are ECG to calculate the QT interval. And we know that in males for 50 milliseconds and in females it is for 60 milliseconds. That is considered as the normal value of QT, corrected QT interval. And QT interval more than 500 milliseconds is a contraindication to start methadone. Some electrolytes like potassium, calcium, and magnesium, these need to be monitored because this can also interact with the QT interval. So these are the baseline investigations. So once you start patient on methadone, then you have to again do an ECG after 2 to 4 weeks of starting methadone. Then next, when the dose reaches 30 to 40 milligram per day, and usually I don't think we will reach or we will need 100 milligram of methadone for pain relief. Usually it is said that 30 to 40 milligram of methadone is the necessary dose for pain relief. And if the patient require more than 30 to 40 milligram, then we are missing something else. So we have to extensively search for what we are missing. And so these are the few investigations and how we will follow up the patient while the patient is on methadone. And most of these patients maybe you will start patient on methadone on an outpatient basis or or when you see the patient in home care. So we usually call the patient every day and ask them about pain relief and how much morphine they have consumed in this dose, and are there any problems like syncopial attack or something like that. And um, I told you before that the steady state will be reached only after 5 to 7 days, and in some patients it will take about 10 to 14 days. So, who are the candidates appropriate to start on methadone? So, methadone is used as an adjuvant. So, this term should not be confused with the term which we use in W-phenolphthisic ladder, the other adjunct. Here, the word adjunct is used in literature when they use the methadone in smaller doses. Then it is termed as an adjuvant therapy with methadone. Suppose a patient who has very well controlled pain on 10 milligram for hourly, but at night the patient need to wake up because of pain. Otherwise, the patient is fine in during morning hours. And when you give a small dose of methadone, 2.5 milligram, that patient will have very good pain relief. So that's what adjunct is described as in case of methadone. And uh, another indication is refractory pain to other opioids. So we might see patients with the morphine or fentanyl. They don't have proper pain relief. So maybe they will be a good candidate to shift on to method. So method one of the safe in case of chronic. Most of the methadone is eliminated from the body by through bowel, and the method. So if the patient require a long-acting opioid, maybe you can convert the patient to opioids. Suppose patient is on 1,000 milligrams of morphine, then maybe in that case the patient requires that much morphine because of the tolerance.
Excuse me, Sunil.
So because methadone is an NM, yeah.
Sorry, we're having a little bit of trouble with the sound. I'm not sure if others are having the same problem. It's just bandwidth.
Speaking, sir, during the last 3-4 I thought it's just for me. That's why.
Sorry to interrupt. I don't know if there's much you can do,
Okay.
but
yeah.
just to let you know.
Am I audible now?
Yeah, you're audible. It's just the sound quality goes in and out. It had just started, but it'll probably correct itself. There's not much you can do, probably.
Okay. So if you can't hear, please let me know. I don't know.
Thank you.
So we know that some patients who are on large doses of methadone or equivalent doses of methadone of morphine of any other opioids, like 1,000 milligram of morphine. So it is because the patient has tolerance to opioid. So tolerance, very simply, if the patient is taking 10 milligram of morphine today and is having pain relief, good pain relief, maybe the pain score is 2/10. And maybe the next week, the patient requires 20 milligram to get the same pain relief for 2/10. And maybe after some time, it will go on to 50 milligram for hourly to get the same pain relief. So to get the same effect, the dose required would be high. That is known as tolerance. So in case of if the patient has or is on high dose of opioid, then maybe methadone is a good choice because NMDA receptor is involved in the development of tolerance. So methadone can prevent and reverse that tolerance. Then if the patient has any opioid induced adverse side effect with any other opioids, then through allergy to any other opioids. Some patients, I have experienced with 1 or 2 patients who had allergic reaction with morphine, and we started them on methadone with good pain relief. So these are the some patients for whom we can start methadone. And there are some patients who are not appropriate to start on methadone. So congenital QT syndrome and family history of sudden unexplained death. The congenital QT syndrome can run in families, and it can lead on to sudden death, which is there is no explanation, or the cause of death is not obtained. In such cases, it may be due to congenital QT syndrome. And corrected QT interval more than 500 milliseconds. And if the patient is living without a reliable caregiver, then that's another contraindication. And if you are unable to follow up the patient, that's again another problem. As we know that methadone will take about 5 to 7 days to get the blood level sustained. Because of that, it is not a suitable drug for acute pain management or acute pain crisis. So these are the two preparations available in India. These are 5 milligram tablet and syrup. 1 ml contains 5 milligram. So I am moving on to methadone conversion. So methadone doesn't have a linear relationship. Means suppose it is we want to convert a patient from tramadol to morphine. So we say that it is 1/10 as potent as morphine. But in case of methadone, we can't say like that. It is depending on the dose of corresponding morphine, how much the methadone will be potent. And you have to understand that there are different types of conversions available. Many types actually available if you look at the literature. So that will make you confused which method has to be used. And there were actually there is no method which is more better than other method, but we use this method of conversion. This is hospice and palliative care consensus method, which is published in Journal of Pain and Symptom Management in 2019. And this conversion, if the patient is opioid naive, or if the patient is taking less than 60 milligram of oral morphine equivalent per day, we can start the patient on 2 milligram to 7.5 milligram per day. 2 milligram to 7.5 milligram per day. That's the initial dose if the patient is taking less than 60 milligram of oral morphine. And if the patient is on 60 to 199 milligram of oral morphine equivalent, and if the patient is less than 65 years old, the ratio is 10:1. 10 milligram of oral morphine is equal to 1 milligram of methadone. And if the patient is taking more than 200 milligram of oral morphine equivalent or more than 65 years, the conversion ratio is 20:1. And whatever be the dose of morphine the patient is on, suppose the patient is on 1000 milligram of 1000 milligram of morphine, then the conversion ratio would be 20:1. And when you convert it into methadone, the dose of methadone would be 50 milligram. That is 1000 divided by 20, 50 milligram. But this method says never start more than 30 to 40 milligram of methadone, whatever be the dose of morphine. And we practically follow this method, and I have seen that this is very useful. And how would you increase the dose of methadone once you start the patient on methadone? And this is if the patient is taking less than 30 milligram per day, the maximum daily dose that can be increased is 5 milligram per day, and 5 milligram per day. Next time when you increase, it will be after only 1 week, after 5 to 7 days. And if the patient is taking more than 30 milligram per day, you can increase 10 milligram. And we talked about the importance of the liver function and elderly people. And in such cases, we should not increase the dose of methadone until 10 to 14 days. So I'm going to talk about a patient. He's a 37-year-old man who had carcinoma of the buccal mucosa in 2018. And he, at the same time, he also had another primary papillary carcinoma of the thyroid, and he underwent surgery and radiation. And 2019, he had level 2 nodal recurrence, for which he underwent surgery. And his main problem is, you can see how this man is sitting. Pain is starting inside the left ear, going back to head, and then to submental region. And he described it as pricking pain 10 by 10. And they did extra oral mandibular nerve block 3 times without any pain relief. So because the patient is still in severe pain, they started him on injection morphine, but he had toxic symptoms. And then they switched on him to tablet morphine, and they started him like this: 10, 15, 30, and 30 milligram. And even with this dose, the patient had symptoms of opiotoxicity. And he was also tried on various adjuvants without much pain relief. And when the patient came to us, he was on these medications: tab morphine 10, 15, 30, pantoprazole 40 milligram OD, ciprofloxacin 500 milligram BD, escitalopram 10 milligram BD, sarashipeptidase, diclofenac patch, and paracetamol. So I just want to ask you, is there an indication to start methadone in this patient? Anybody can unmute and speak.
Would anyone like to suggest to respond to Dr. Sunil's question? Do you want to repeat the question, Sunil, just in case people didn't catch it?
Are there any indication to start this patient on methadone? If yes, what are the indications?
I am Dr. Rajni Sinha.
Yeah.
I want to ask whether the patient had initially responded to morphine initial doses, or whether he was like resistant, or he did not had any effect with morphine, or the.
Yeah. So Dr. Rajni, the patient was given injection morphine with which he didn't had satisfactory pain relief. Instead, he had myoclonus and delirium. And so they didn't. This patient came to us from another institution.
Okay.
So and then they started him on tab morphine.
Okay.
This is the dose. With this, he didn't had maybe very little pain relief.
Okay. In that case, I think that there is indication of methadone.
Yeah. So what are the indications?
First of all, he did not had pain relief with morphine with increasing doses, or initially also when he was given injections, he did not respond much. So this means that even after increasing the dose of the morphine, he will not respond as expectations. So changing the drug would help. I think so. Okay.
And another thing is, you can see from the description, the pain is like neuropathic pain. And
neuropathic. pain.
The patient had morphine
Morphine
toxicity,
toxicity. Yes, yes.
and maybe not responding to other opioids like morphine.
Yeah.
So these are a few indications by which we can proceed to start this patient on methadone.
Yeah.
So before starting on methadone, what are the questions that you will ask to the caregiver or to the patient?
The same contraindications of methadone, like is there any history of sudden death in the family?
Yeah.
Or is he having any cardiac problem,
Yeah.
like QTC interval, as you said? So all those questions I
Yeah.
would like to ask.
Yes, very good. So a history of any sudden unexplained death in the family. Then another important question is there any reliable caregiver? So if there is no reliable caregiver, I think we should not start the patient on methadone. It is not like morphine. If you start patient on methadone, on morphine, the results will be seen after 24 hours or maybe maximum of 36 hours. But in case of methadone, the effect will be seen suddenly after 5 to 7 days. So by that time, the methadone has accumulated in your body. And if the patient is on taking this, do we actually need to do an ECG in this patient?
Yes, I think so, because we need to see the QTC interval.
Okay.
No.
Yeah. But what I want to tell you is that whenever we do some investigations or interventions, it should be aligned with goals of care. So what are the goals of care in this patient? This patient had two primaries for which he underwent treatment, but the disease is progressing. There is no palliative oncological intervention existing. They stopped all the interventions. So in that case, our goal of care is now comfort care. So maybe I think I need not do any investigation in this patient because our goal of care have shifted to comfort care. So maybe ECG is not necessary, but if somebody is starting methadone for the first time, it is good to have an ECG. And what else? Electrolytes. Which are the electrolytes?
Does anyone want to suggest what the electrolytes might need, what might need to be checked?
Magnesium, calcium.
Yeah, magnesium, calcium, and potassium. These are the three electrolytes which we have to do. Then, do you have any concerns in this patient with present medication? I told you that there are many medications which can interact with methadone because of the cytochrome P interaction. So these are the present medication the patient is on. Any concerns?
We're all trying to remember our pharmacology again.
Yeah.
We have got a pharmacist in the group. Maybe I can put Penny on the spot. But you can wave your hands and say no, Penny, if you'd rather not.
I could feel that coming.
Could you? Sorry.
I'd be a little bit concerned about the ciprofloxacin.
Okay.
Thank you. Anything else? So, escitalopram is something which can have interaction because methadone is it acts like a tricyclic antidepressant. and we are giving acetalopram. When we combine both, it can precipitate something known as serotonin syndrome. So that might occur theoretically, but um, I haven't seen any patient with serotonin syndrome, but still it is possible to have some interaction with the methadone. And pantoprazole is another medication which has some interaction with methadone. Fluoroquinolones, any fluoroquinolones. So ciprofloxacin is one of them. So that's another concern. So escitalopram, pantoprazole, and ciprofloxacin. So actually, this patient, escitalopram was started by the other palliative care center, thinking that this patient is in depression. But actually, this patient was not in depression. He had severe pain. That was his problem. So how are we decided to start this patient on methadone? So how do we calculate the morphine equivalent, oral morphine equivalent, or morphine equivalent daily dose? So this patient is taking, you can see this patient is taking morphine 10, 15, 10, and 30. So the total dose of morphine he is taking is 30 plus 10, and that is 65 milligram of morphine. So what would be the conversion ratio? 65 milligram of morphine. The patient is taking
10:1.
Yeah, 10:1. So the conversion ratio is 10:1 because it is between 60 to 199. Yeah, 60 to 199 milligram. And this patient is less than 65 years old. So 10:1. So the total dose would be 6.5 milligram of oral methadone. So you can either start the patient on tab methadone 2.5 milligram BD, or if you have syrup methadone, you can start him on 3 milligram BD. So
Dr. Sunil Kumar,
yeah,
hello.
yes,
Dr.
yes.
Kale from Nagpur.
Yes.
Is it a OD dose? The dose of methadone?
Methadone, the duration of action is 8 to 12 hours. So
Sunil, could you repeat the question? Couldn't quite catch it. From Dr. Kale.
Yeah.
Yes. Is it a OD dose or a BD dose?
So methadone duration of action is, can you hear audit?
In here, but it's a bit muffled. I'm just wondering if you could repeat the question so everybody can hear.
Dr. Kale was asking whether methadone can be given as OD dose, once daily dose.
Right.
So methadone, the duration of action is 8 to 12 hours. So usually it needs to be given either twice daily or 3 times daily. But I told you in certain situation it is used or given once daily, and then it is used as an adjunct.
Okay.
So in this patient, the methadone was started 2.5 milligram BD, and we know that it will take about 5 to 7 days to have the sustained blood level or to get the good pain relief. So we have to continue the morphine with as a SOS dose every 4 hours. So usually we give morphine 10 milligram 4 hourly and SOS, but here it is 10 milligram 4 hourly as SOS dose. So that means you give methadone, maybe 6 AM you are giving methadone, and at that time you will ask the patient, do you have pain? If the patient has pain, you will give morphine. And again at 10 AM you will ask the patient, do you have pain? Patient says, no, I don't have. Then you will not give morphine. Then 2 PM again you will ask. And if the patient has pain, you will give, otherwise you will not. So that's what 10 milligram 4 hourly SOS means. So this patient was given tab methadone, morphine, paracetamol was regularized, and instead of fluoroquinolone, we started him on amoxicillin, and pantoprazole was stopped because it was unnecessary. Then escitalopram was also stopped in this patient. So this is how the conversion was done in this patient. I think we have another patient whom we are going to discuss. So we get more clarity on this. But I fear that the conversion method is something else which she is going to mention. So that we'll discuss. What what you need to understand from this is methadone, even though methadone has drug interaction and it can increase the QT interval, but the important thing is that the studies with on QT interval regarding methadone is mainly from patients who are on substitution therapy with methadone. And these patients, most of these patients will be on hundreds of milligrams of methadone. So as the dose of methadone increases, the chance of QT interval increase is also possible. So the dose which we use in palliative care to use it as an analgesic, the dose is very less, maybe less than 50 milligram per day. And even MD Anderson Cancer Center has conducted a study, and they have given, I think they followed up about 100 patients who were started on methadone, less than 50 milligram per day. And they found that there were no, they didn't found out any Pausaday points or ventricular fibrillation. That's one study which we can say that if you use methadone in doses less than 50 milligram, it is not going to be or it will not cause much increase in QT interval or lead to any complications. And we also need to be aware of the interaction interaction with other medication. There are most of the medication which we use in palliative care has many interactions with methadone. The benzodiazepines, SSRIs, fluoroquinolones, and macrolides, many medications. But we need not fear about this. You should be careful while you use methadone. So the message is you have to respect methadone, but it is very helpful in a group of patients who has poor pain relief with other opioids, and in patients who has allergy to opioids. So thank you.
Thank you very much, Sunil. It's a complicated and quite a vast topic, and you've managed to cover so many, not only the theoretical, but a lot of the practical points as well in that talk. So thank you very, very much. I'm conscious that we're really trying to leave some time for breakout rooms in today's session. So maybe if we just have one, perhaps two questions max, if anyone does have a question for Sunil.
Yeah, again, Dr. Rajni.
Dr. Rajni.
Yeah,
can you remind me where your service is, Dr. Rajni, just so we all get to know each other a bit more? Where are you based? Hi.
Hi. So I am presently working as a physician. I was working in Mahavir Cancer Sansthan at Patna, but now I am doing independently. So I just wanted to ask that how frequently we need to increase the dose of methadone if the patient is not responding. Should we assess after a week, 5 days, or after a week? How we need to escalate the dose?
Yeah, thank you. That's an important question. We know that methadone will take about 5 to 7 days in healthy people to have a sustained blood level, to have good analgesic action. So it is better to wait for 5 to 7 days before you increase the dose. That is in healthy people. But if it is elderly or patients who are having altered liver function, then would be better to wait for 10 to 14 days.
Okay, thank you so much. So we
sorry, carry on.
Yeah. So as methadone has lot of drug interactions, so we should be more cautious in writing all those antidepressants. Like more frequently, we write amitriptylines and the SSRIs and all. So we need to hold those medicines and then be cautious, right?
That's an important question again, because we know that there are many drug interactions. But when we started methadone, we were hesitant to start patients on methadone because we know that this has many drug interactions. It can increase QT interval. It can lead to toxidependence. So all these were taking us back from prescribing methadone. So we were frequently getting in touch with our mentor to ask about these questions. What should we do? So when we started methadone, what we did was the prescription should be very simple. As you told, there should not be many medications. That is one of the important points that we did when we started a patient on methadone. But after a few patients, then we gradually understood that even if there are this medication, all the medication will not cause much problems. But I have told you, if the patient is on fluconazole, that is going to be a problem. So that you will understand from your experience. That's what I want to say.
Thank you very much, Dr. Sunil and Dr. Rajani. So let's move on to Dr. Jessica's presentation. Jess, do you want to share your screen? Have you got access to share the screen, or do you need us to?
If you could do that, Adette, that would be great, if possible.
To give you screen sharing, or for us to show the?
If you could show the slides, that would be
Here it comes.
Fantastic. Great, thank you.
Onto the game. Great.
So
you, Jess. Thank you.
Thank you so much for inviting me. So my name's Jess. I work in Canberra at the local hospice, and as Adette said, I mainly work in community palliative care. If we could go on to the next slide, please. So I'll talk about a chap, 69-year-old man, who I'll call Nick, and he had a diagnosis of probable squamous cell lung cancer. Next slide, please. So really his cancer history started in January of last year. He developed a right thigh pain, and investigations, a CT showed probable metastatic disease. Nick went on to have a biopsy, which showed a poorly differentiated squamous cell cancer. Next slide, please. So he went on to have a CT, chest, abdomen, pelvis, and PET scan, which showed it was likely that he had a lung primary. He was admitted to hospital and had a right femoral fixation and subsequent radiotherapy. He also commenced triplet chemotherapy, immunotherapy with carboplatin, pemetrexed, and pembrolizumab, and then he followed that with immunotherapy. But unfortunately, in July, he was found to have progressive disease, and he recommenced chemotherapy. His staging scans in August showed a partial metabolic response to treatment, and in October, he was referred to palliative care, where he really saw my colleague in outpatient clinics, and he did fairly well. He was on 20 milligrams twice a day of sustained release morphine. By January of this year, things started to, get more difficult. He was admitted to our local hospital with back pain, and my colleague and I both work at that local hospital. It's a smallish hospital, doesn't have medical or radiation oncology, doesn't have MRI machines and so on. But he had a CT scan, and that really showed very, very extensive metastatic disease throughout his spine and pelvis. And in hospital, he had his MS content increased. MS content's the sustained release morphine that we use in Australia. It was increased to about 45 milligrams twice a day. And really he started to become delirious on that dose. So we stopped the sustained release morphine and commenced a hydromorphone at 1 milligram every 4 hours, and that was given subcutaneously. And then later on, we put that in a syringe driver over 24 hours. So it was 6 milligrams of hydromorphone in a syringe driver. His pain, however, continued to worsen. And so he was transferred to the tertiary hospital where he could get radiation oncology input. And they did give him a radiotherapy. And he was discharged on 32 milligrams of oral hydromorphone. Next slide, please. But he really only lasted at home for around 8 days before he was admitted to the local hospital where my colleague and I work, and he had worsening pain and confusion. And it was at this point where we commenced methadone. We started at a really low dose and we used it as an adjuvant. So in Dr. Sunil's presentation, there was a complete rotation to methadone, whereas we used it more as an adjuvant. So we started off at 2.5 milligrams a day, and then very quickly went to 2.5 milligrams twice a day. We took him off the long-acting hydromorphone and put him on a 4-hourly subcutaneous hydromorphone regimen. And, we also, advised to complete a delirium screen and so on and so forth. And then a few days later, his delirium was still ongoing, his pain was worse. So we increased his methadone at that point. And then again, a few days later, we increased his methadone. And by the 50, so about a week after we'd started the methadone, he was very comfortable, but he was quite drowsy. So we reduced his hydromorphone. And then we continued to try and reduce the hydromorphone to see if we could improve the delirium. His delirium did improve slightly, but his pain was worse. So we obviously increased his methadone. As you can see from this case, we actually did it faster than what Dr. Sunil had discussed in his presentation. We were probably increasing his methadone every 3 days. And I think that because this man was in hospital and we were using it as an adjunct, we were okay to increase it more quickly. Certainly, if this man had been in the community, I wouldn't have been increasing his methadone this quickly. If he'd been in community, I would have definitely been waiting those 5 to 7 days, like Dr. Sunil had discussed. Next slide, please. Nick was transferred out of the hospital into the hospice, and he was on 5 milligrams of methadone in the morning and 7.5 at night, with a small amount of hydromorphone in the. He was transferred to the hospice where he basically became clear that he was dying. So we've converted the oral methadone to a subcutaneous form, which is a 2 to 1 conversion. 5 milligrams in the morning, 7.5 at night. Kept him on the syringe driver with the hydromorphone in, and he died, fairly comfortably the following day. Next slide, please. So I thought I'd just, so that was really the history of how we, use methadone. and how it really did improve his pain. And it did somewhat improve his delirium. So just as in Dr. Sunil's case, we used it because the opioid was not his pain was not particularly opioid responsive. I think he probably had neuropathic element from his cancer-induced bone pain, and also because he was opioid toxic with the delirium. So very, very similar indications to Dr. Sunil's case. The other medication he was on a smidge of gabapentin, and that was really for cough. He was on paracetamol. He was on a non-steroidal anti-inflammatory. He was on medication to help improve sleep, so some melatonin and some temazepam. He was on bowel medication, and he was also on pantoprazole and some aqua spray. Next slide, please. So what were the psychosocial aspects of this case? So I think certainly he had a delirium, and that made engaging with his family really tricky, because this was at a time where there was stringent visitor restrictions in the hospital. So Nick wasn't allowed any visitor restriction. It wasn't allowed any visitors, and so his delirium made it really difficult for him to have good quality conversations with his family, especially over the telephone. And it also made actually his pain history quite tricky. Also, his prolonged hospitalization and isolation meant there was significant distress from himself, but also from his family. Next slide, please. And the main concerns of the patient so was the disjointed medical care. So he found it really tricky being in the smaller hospital where he didn't have access to radiation oncology or his medical oncologist. This second big concern was his isolation due to COVID, and the separation from his wife, and also his ongoing pain. Next slide, please. So in summary, this was a 69-year-old man. He had aggressive cancer with pain, really only properly controlled after introduction of methadone. Next slide, please. So I thought that the discussion points could be: why did we start methadone? Evidence for how to rotate or to commence methadone, and maybe the evidence for adjunct methadone. But before I discuss this, did anybody want to clarify any points from the case?
Thanks,
Hello.
Jess. Oh, can I just ask you to say something about hydromorphone, Jess, because it may not be familiar to people?
Yeah, sure. So hydromorphones, an opioid we use fairly commonly in Australia. It's got 5 times the potency of morphine. It can be given as an oral and an injectable form, and we tend to use it if there's renal impairment. So of course, if there's really significant renal impairment, fentanyl and methadone are the go-tos. But hydromorphone can also be used, cautiously in renal failure, because there is fewer metabolite buildup in renal failure with hydromorphone compared to morphine.
Were there any other questions, clarifying questions for Jess about this case and the management? Just anything that you may not have followed?
Hello, Dr. Khalid.
Thank you, Dr.
When the patient is on methadone, do you need to continue other celecoxib and paracetamol, etc.? Because the pain methadone will take care of the pain. So why other medication should be continued?
Yeah, so I think this man's pain was really tricky to control. I think we continued the celecoxib in case there was like an inflammatory component to the pain, which the celecoxib would treat. I think we were also really trying to reduce the opioid in this man with any adjuncts. We also consulted interventional pain management as well, because his delirium was so impacting on his quality of life that any analgesic method that didn't contribute to his delirium we wanted to keep on board. Does that make sense?
Okay.
Okay. So if there's thank you for that. Thank you for those questions. So I suppose, why did we start methadone in this man? So I suppose we started it because he'd had a poor response to opioids. He tried sustained release morphine and hydromorphone, and he continued to have poorly controlled pain, and he was experiencing opioid-induced neurotoxicity with the delirium. I think the second reason we started it was because his pain history was difficult to elicit with the delirium, but we suspected that there would be a neuropathic element given there was bone pain and nerve root compression. And as Dr. Sun-Hill explained, the S-methadone, sorry, got a bit of sore throat, is really good for neuropathic pain. We could have started other anti-neuropathic pain agents, but I think we were really cautious about that, given that they can also potentially worsen delirium. But also, I think methadone's a really nice anti-neuropathic agent because you can use it as in a subcutaneous form if near the end of life, which is particularly important for Nick, but also if for other reasons you don't have a good absorption via the GI tract, you can use methadone subcutaneously. And then I think also I tend to really start thinking about using a bit of adjuvant methadone when patients are on around 60 milligrams of oral morphine equivalent, because I really worry about the risk of opioid hyperalgesia with increasing up the opioids. So that's why I started methadone in Nick. And then looking at the evidence for how to rotate to or commence methadone, I think Dr. Sun-Hill really covered this so well, so I won't rehash it too much. But what I do in practice, especially when I work in community, is I start methadone really cautiously. I always advise about side effects, not only to the patient but also to family members. I'd never start methadone in community in somebody without, as Dr. Sun-Hill said, a reliable caregiver. And I also really explain what to do in the event of side effects. I always make a phone. Oh, sorry, Tom, could I have some water, please? I always make a phone call around day 3, just to check that there's no, significant side effects from the methadone. And I always start around 2.5 milligrams a day for 2 or 3 days. And then I increase to 2.5 milligrams twice a day. And then I would wait and increase every 5 to 7 days. And if somebody's on another opioid, and generally I would never really start methadone as a first line opioid. So when their pain's improving, thanks Tom, then I scale back on the other opioid. And if I'm concerned about potential overdosing or causing opioid toxicity, I tend to try and use 4-hourly short-acting opioid. I think Dr. Mather-HIllon's talked about rotating to methadone. In Australia, we tend to use the in Victoria, we tend to use the iron Rinden bridge conversion ratios. And as Dr. Mather-HIllon said, there is multiple ways that you can rotate to methadone, and none of them have got complete consensus. The iron on Rind method is an older method, and I think that's why it's had history of use in Victoria in Australia, and also it was a safer method than some of the other rotation methods. There was less risk of opioid toxicity.
Jess,
and then,
could I be rude and interrupt? I'm conscious of your sore throat, and it sounds really quite painful, and you're battling on very bravely. But also, I think Dr. Sunil probably covered a lot of the adjunct methadone, and it would be great to kind of have a little bit of time for the breakout rooms. Do you mind just if there's any last comment you want to make? But you're on mute. Sorry, you're on mute.
No, I'm all good. I think Dr. Sunil covered so much. So yeah.
Thank you. And I didn't realize you were struggling with sore throat. So thank you very much for going into this anyway. It's very brave of you. So it's just with our feedback, we've had requests that we really leave a bit more time for participation, and so we're really keen to move you all into a small group where you just, if you could just talk about whether and when you think you might use methadone in your practice. I mean, those of us who work in Australia probably have had more opportunity to use methadone and develop some familiarity with it. But for many of our colleagues in India, this is a new topic, a new drug. And so it would be really interesting to sort of hear what experience is in the group, and whether those of you who haven't had an opportunity to use methadone, it might not be available where you work in your particular state or service, but whether this presentation and discussion has kind of piqued your interest, and maybe whether you would consider using methadone or see the advantages at least. So shall we just go into the breakout rooms? It's only probably about 10 minutes or so, and then we'll all come back and share our discussions. Thanks. Thank
you, Dr. Odette. So launching the breakout rooms, the duration would be 10 minutes, and you'll be getting an intimation in your screen to join the rooms. Please do accordingly. Opening the rooms.
Welcome back, everyone. You may have been mid-sentence, as we were when you got whisked back into the main group, but time is, as always, running a bit against us. But would I was going to ask you in the chat, David, but there's no time to ask you in the chat. But would you be happy just feeding back a little bit from our discussion? And if any and others prepare to feed back a little bit from your groups, David, would you be happy to? You're on mute at the moment. Sorry.
That's okay. It happens all by itself. Well, look, I mean, I think we agreed, and certainly it's my view that that methadone is a very useful analgesic. I think one thing that might have come out of our discussions previously could have been that it seems to be a better analgesic for neuropathic pain and for complex pain than other opioids. But that aside, I think our discussion of the side effects of the drug has led us to an impression, maybe I'm wrong about this, but if you have the impression tonight that this drug is potentially substantially more dangerous than other opioids, I think that might be unfair. The drug does have some particular issues, but you take those into account, I think it can be a very useful and safe alternative drug to the usual opioids. I think that's, Odette, if you agree, I think that's the main thing I'd want to say.
Yeah. I agree. Both as an adjuvant and as a mainstay painkiller in its own right.
Yes.
Anybody else? Yep. Anil?
I just wanted to briefly mention that it was I was very interested in our group to hear that in India, injectable methadone is not available. And the second point was that there are only a small number of centres using methadone. So I'd just like to reiterate what David is saying and encourage people to just gradually build up their own prescribing confidence in using this for their patients.
And would you say that starting off using it as an adjuvant might be the simplest way to go? That sort of 2.5 milligrams daily or something like that?
Absolutely, yes. So certainly in our group, I mentioned the dose of 2.5 milligrams twice daily, to be honest, but yes.
Absolutely, yeah.
In our group, we were discussing about talking with families and patients about the side effects, and Tara had a question about if the family present to you their concerns, what is how do you explain that to the family? And I think, what we were saying about, not being afraid of using it and making sure that we know that we're keeping a close eye on them and we're starting off at a low safe dose rather than scary, you might die if you start this medication.
And also in the chat, Dr. Booty, you asked earlier, why use methadone over morphine? What are the advantages over morphine? Do you have a sense of that as a result of some of the discussion, or would you like to ask for more input onto that question?
Okay, I'm sorry, I actually missed the beginning of the presentation. I was just wondering why the methadone was used instead of morphine, because I'm from Bhutan and I have not seen tablet, forget about injection, I have not seen tablet methadone too. So I wanted to know more about the tablet methadone.
Sure.
That's all.
Neil, I think that was during your presentation, so I don't know whether you've got a couple of insights for Dr. Booty just to answer her question.
Okay, so Booty, methadone has many mechanisms of action. One is it acts on opioid receptors like any other opioids, but it also acts on mu, kappa, and delta opioid receptors. So all the opioid receptors it acts on. And another mechanism is it has NMDA antagonistic activity. So how much efficiently it acts on NMDA is another question, but it has NMDA antagonistic action. So that makes it more important to treat the complex neuropathic pain and opioid-induced hyperalgesia. and also in high opioid tolerance because NMDA receptors are involved in tolerance as well as hyperalgesia. Sorry.
Great.
And it also has tricyclic antidepressant-like action. So it inhibits the reuptake of noradrenaline and serotonin. So these are the mechanisms by which methadone is going to help with complex pains. So it is different from other opiates. So that's why methadone is chosen when you have complex type of pain.
Thanks. And there's one question from Dr. Kandawal in the chat about brand names in India, Sunil or Shri or somebody. Can you answer that?
Okay, it's RMeth. RMeth. It's only one pharmaceutical is making this methadone. It is RMeth.
Is it ARMET, is it?
Yeah, METH. R capital R.
RMET.
METH.
Great, thanks. Any other feedback from the groups or questions?
Hello. From,
yes.
The person is from Assam. He said methadone is not available there. And he said that they need a different license for that. They have a license for morphine. But I think Dr. Sunil Kumar can throw some light on that. If the institution is using morphine, they should be able to get methadone, and there should be no hindrance in getting methadone. Please, Sunil Kumar sir.
Yeah. So according to the amended NDPS Act, we need to have only the RMI status, the recognized medical institution status. If you have RMI status, then you can get methadone with that.
Okay, I have told him to talk to you regarding that. Thank you.
Yeah, so you don't need any special permit for methadone. Thank you, David. You just need the RMI status. That's good. All right, well, we better wind up unless somebody's jumping around with a question and I'm missing you. Apologies. But I think we've got a couple of minutes to go. So I just wanted to thank you all very much for participating, and thank you to the speakers again, Dr. Sunil, Dr. Jess. Great presentations on a really important topic. And I wanted to mention the feedback that some of you gave us about the sessions. That we sent out a quick survey about a month and a half ago about the topics and what other topics people would like. So that was really helpful. We had about 16 respondents. Some of the topics people asked for were malignant bowel obstruction, management of the patient with end-stage renal failure, neuropathic pain and cancer, collusion, breaking bad news, self-care, universal healthcare, working with policymakers, with drug controllers, developing palliative care teams, and others, including community-based palliative care development and spirituality. So some really great suggestions. I think quite clearly people want some good, strong clinical topics. But also there was some requests for repetitions of some of our previous topics, like having difficult conversations, opioid availability issues in India, and nursing issues. There was one participant who asked for that a repeat session for nurses. And again, just asking very much if we could increase the amount of participation. One person said, I was unsure how to participate and hope to participate more than listen. So I think that's sort of where the real benefit of the ECHO program can be, of allowing people to really interact with each other. So we'll keep working on that. It takes a little bit of time to happen, I think. So, and then finally, just to say that our next session is on the 14th of June, and the focus then is on that session is opioid prescribing. And Dr. Anil is presenting, and we have Dr. Rita Rani. Some of you may have remember she gave us a presentation earlier in the program about the progress in opioid prescribing in Bihar, particularly at her service in Mahavir Cancer Center. And we'll be looking for a couple more people from India or possibly Bhutan, to talk to us about the sort of status of opioid availability in their state or area or country. So really looking forward to that, and thank you, Anil, for presenting in advance. Thank you. And I think that's all. Does anybody have any last questions or comments, or shall we sign off?
I think Dr. Anil had raised his hand. Dr. Anil. Thank
Okay.
you. Thank you. Thank you everyone for joining us. I believe that this was a really interactive and a helpful session for everyone out there from different parts of the world. And we do look forward for such interactive sessions in the coming days also. So with that positive note, this is Sripriya along with Dr. Odek, Dr. Sunil Kumar and Dr. Sridevi signing off from the TIPS ECHO Hub. See you in the next session. Till then everyone, take care, stay safe. Bye-bye.
See you everyone. Bye.